We asked breast surgeons why they trust CubTech for intraoperative specimen imaging.
Going over to 3D technology has dramatically changed my practice. We're not only using it for lumpectomies, but even mastectomies, especially when we're worried about close nipple margins with nipple-sparing mastectomies. And just tracking my own personal data, I would say I've probably dropped my re-excision rate from about 15% down to single digits. I think the last time we looked, it was about 2%.
What I like about CubTech is the ability to have that 3D image. You can place your specimen in the radiograph machine and you can see all 6 margins in one x-ray.
When it comes to specimen imaging, there's only one name you need to know. It's CubTech.
Welcome back to the Mood Food Podcast and our special Breast Cancer Awareness Month series. We're going to be talking today to Dr. Camelia Lawrence, who's a powerhouse breast surgeon, and Dr. Pram, who's on this journey with me, who's a naturopath. We've had a few other episodes that we've covered with our medical oncologist, Dr. Jessica Trevino-Jones, and Dr. Sunil Krishnan, who's a radiation oncologist. We've spoken to a couple of patients before this as well who've gone through breast cancer. I hope you've had the chance to look at those episodes. And if you haven't, please go back and take a look at those in our show notes. Today, we're continuing that journey by focusing on what happens when surgery becomes part of your treatment plan. So, Dr. Lawrence, what first inspired you to pursue breast surgery as your career path?
I wasn't always interested in breast surgery per se. I've always been intrigued by medicine, the art of healing. And I think that is rooted in my upbringing. I grew up in a developing country where we didn't readily have access to healthcare. And as a young child, I remember my grandfather was afflicted with epilepsy and being able to access the care that he needed. And so I think from then I've always been interested in medicine and the art of healing. And then early mentorship is really what got me interested in breast care per se.
Okay.
Yeah.
So, no personal journeys, so to say, that kind of inspired your way into this, but more of what you saw
Growing up, yeah. And for women's health, I have always felt as if didn't necessarily always have the priority that's needed. So when I started medical school, I met a young surgeon, Dr. Gretchen Arndt, and I asked her if I could shadow her. And she said, yeah, she came to give one of her medical school lectures, and I was smitten. I went into the operating room with her. I saw what she did. It all appeared so magical. I was able to see the patients post-operatively. I saw in real time the impact of her work and her intervention. And I think that solidified my interest in breast surgical care.
And that's fantastic because we need more surgeons like you that are so compassionate and caring. That's kind of what I've gotten from, all the people that I've heard from. So thank you for doing what you do.
Well, I love what I do. I often say it is my calling. I can't imagine doing anything else. So it's a good fit.
That's great. So you've combined leadership, clinical practice, and community service. How do those different roles influence each other in your daily work?
I'm very actively involved in community service. And I think community service informs leadership as well as clinical practice. It ensures that our decision making, including our clinical decision, they're sound, but also that they're socially responsive. We are able to make decisions and develop programs and strategies that really prioritizes the patient experience. So it's really having your finger on the pulse through community service, both sort of informs and elevates the other.
I think that's exactly right. Unless you know what your patients are going through, it's very difficult to deliver on care that is compassionate and that matters to them.
Exactly. So by being engaged with the community, it really equips you to make decisions that are grounded in the realities of those that you serve.
Right, right.
Yeah.
That's fantastic. That's good to know that somebody actually is out there interacting with people who are going through the journey
Yeah.
and understanding exactly what their needs are
hmm
and then kind of providing service, or I would call it service, you
Yeah.
know. And I always call the medical profession is a very noble profession. So bringing someone from dis-ease to ease
Hmm.
is a journey.
Yeah. Yeah. I also think it builds credibility and trust.
Right.
You
That's true.
know,
I admire you.
oh, that's
I admire what you've just said. And I know that surgery and the work you do is not only a science, but an art,
mhm.
correct?
Well said. Yes.
And I'm really excited to know all those things that are the finesse of what you do,
Hmm.
and how myself as a naturopathic physician, coming from a culture that did Ayurveda and natural medicine, studied that in this country, how that all interfaces
Hmm.
in the culture that you're serving.
Hmm. Very important.
Yeah.
Yeah.
So the other question is, you've done a tremendous amount of work. So you were instrumental in launching the breast center at the Plainville Cancer Institute. What vision guided you in creating a new model of patient care? And can you kind of explain to us what was the new model?
Yeah. So the Cancer Institute at Plainville was in existence prior to my arrival. They were actively seeing and caring for cancer patient. When I onboarded, I saw an opportunity to further build on the infrastructure that was already in place, and was lucky enough to secure the buy-in from those other key stakeholders.
Right.
Because everything that I am able to do, you may see my face, but there's an entire team. There's an army behind me and alongside that makes all of this come to fruition. And my focus really was, how can we improve access to diagnosis, treatment, and turnaround time, in particular for biopsy results? It was really centering the patient's need. And I'll tell you where this stems from. It's having experienced friends, family members, having an abnormal study, whether it's a mammogram or ultrasound, and being asked to wait additional days or weeks for the remaining studies that are needed or the biopsy that's needed to clinch a diagnosis, and the anxiety and the worry that comes along with that. And I wanted my team for us to be a part of that solution. So in doing so, the pendulum sort of shifts control per se from the practice and the physicians, and really centers it on the patient's need. So in my experience, any woman that's been told they have an abnormality within the breast, whether they've appreciated themselves or a clinician has found it, or it's abnormal imaging, they want to know, like yesterday, do I have cancer or not? And that's what we're able to do through the model within Hartford HealthCare, especially the Cancer Institute in Plainville, is that a woman can come in, be seen the same day, have her mammogram and her ultrasound if warranted. And if an abnormality is identified, she's offered the option of a same day consultation and biopsy. And in working collaboratively with our pathologist, the turnaround time on average, sometimes we can tell a woman within 24 to 48 hours whether she's facing a cancer diagnosis.
That's
And
phenomenal.
that is, yeah, that's a game changer, not just for
Definitely.
the patients, but their family and their support system, and those who want to know that mom is going to be well, or my aunt, or my sister, or my wife is going to be okay. So that's the change in the vision.
That also produces trust
Yeah.
in the system,
Mhm.
right? Because now everybody's in that network.
Mhm.
And that's important.
Yeah.
Because part of all of this in the good old days was the mystery,
Yeah. The unknown.
the unknown, and the C word, meaning, am I going to die?
Mhm.
You know, nobody had this network of people who understood and moved them through the unthinkable to the thinkable.
Yeah. Yeah. And what I try to tell a lot of patients as well, an abnormal mammogram doesn't mean you have breast cancer. And the good news is that the overwhelming majority of time, it's benign. It's not, but you want to get to that phase. You want to get to that chapter where you hear those words, we're not dealing with a cancer diagnosis. And alternatively, if you are in the right place and we can get the process started to make you whole and to heal.
All right, Dr. Lawrence. So when someone receives a diagnosis, what are the first steps they should take?
More often than not, I tell my patients, take a deep breath. Because as we talked about earlier, the word cancer can be so frightening. We start thinking of way worst case scenarios. And once you've taken a deep breath, I reassure them that breast cancer is a treatable disease in a majority of cases. And then we get down to the logistics. I think it's very important for you to identify your team up front in terms of where am I going to be treated? And preferably, if you have access to being treated at a accredited breast center that utilizes a multidisciplinary approach to care. And why is that important, you might ask? Well, the management of the breast patient transcends just the surgeon, myself. I am part of a large team of multidisciplinary experts. The management of the breast patient also includes you may need chemotherapy, you may need radiation, you may need occupational therapy. There's so many other components that are integral to the successful treatment of your cancer that you want to be in a place where you can harness all of those resources. And so that's typically what I tell my patients. And luckily for me, I'm in a system where all of those resources are available. So I reassure them that they're in the right place. And yeah, and then we get down to the logistics of what is needed next. We've clinched a diagnosis. Do you need additional studies prior to mapping out your surgical plan? We now know that surgery is not always the first line of treatment for every breast cancer. In some cases, they may be better served by starting off with neoadjuvant chemotherapy, which is chemotherapy before surgery. So after we get down to the nitty-gritty of those details, if the patient warrants neoadjuvant chemotherapy, we refer them to meet with our medical oncologist. We discussed just about all of her newly diagnosed cases as part of this multidisciplinary team. Yeah, because we now understand and we know that not all breast cancers are the same. And so we need a more personalized and individualized approach to treating every woman that walks through our door with a diagnosis of breast cancer.
Who actually makes that decision or plan?
It's a team plan.
It's not just you as a surgeon.
No,
but
it's not exactly. And that's why we have the multidisciplinary team, which it's usually a medical oncologist, there's a radiation oncologist, there's a pathologist, there's a nurse navigator. It's a whole disciplinary team that looks at the case to help guide the decision
like you
regarding.
need the chemo before the surgery or surgery before the chemo.
Correct. So I would say the majority of surgeons will be able to identify a patient that needs chemo before surgery. There's certain clinical trials that have clearly delineate the subset of patients where unequivocally they benefit from having chemotherapy before surgery. So we have that structure already in place. So for example, if I'm seeing a woman with triple negative breast cancer, that's the buzzword, a lot of folks have heard about it. It's a more aggressive type of breast cancer. If that woman has a tumor that is 2 centimeters or greater, and or if they have lymph nodes that is involved, there is data that shows that that woman would benefit from systemic chemotherapy before I rush them off to the operating room. So to take them to surgery first, it's not the right thing to do for the patient. So I refer that patient to see the medical oncologist. In addition, we have a team discussion at the multidisciplinary tumor board in terms of what agents are being considered, and an algorithm is mapped out for that particular patient.
That's a lot of different people coming in together to actually map out and customize someone's treatment plan.
Yes.
It's a lot of articulation of different resources. It's something that I think all patients should understand, where they're going, what they're getting in terms of treatment, the service that they're getting, all the resources that come together for them. Um, this is why we're doing this, so that we can create that journey for the patients to understand what's the best way to approach their treatment. So I think, can you explain where surgery fits into the bigger treatment picture alongside chemotherapy, radiation, or hormone therapy?
So I usually break it up into three arms for my patients when we meet and we're having that initial cancer discussion. You've got the surgery piece, you've got the chemotherapy piece, and chemotherapy can be systemic or it could be oral agents, which
Right.
means a pill that you take. And then you have the radiation. And what I tell them from the outset is that not all breast cancer patients will require all three arms.
Okay.
So because you have breast cancer doesn't mean that you need chemo and you need radiation and surgery. There are patients who may only need surgery.
Right.
There are patients who may need surgery plus chemotherapy.
Okay.
There are patients who may need just surgery plus radiation. And there's also a subset of patients that may need all three, surgery, chemo, and radiation. And that's all rooted in an understanding medically of your cancer, your stage, the type of cancer you have, whether there's lymph node involvement.
Right.
We also take into consideration the comorbidities is the word that we use in the
Correct.
medical lingo, but what it really means is what are your other medical issues and how does that impact your ability to tolerate certain treatment? The goal is survival.
Correct.
The goal is to have you healthy again and be able to lead some good quality of life. So if what we're offering will not allow you to have that quality of life that you would like because of your other medical issues, then we have to pivot and balance that as well.
I think that's a very important part of, all treatments. I want, people to understand that life doesn't end when you're told it's cancer. You should plan for post-treatment because there is life after treatment, and that could change drastically once you've gone through treatment. So what are the components that affect you, post surgery? So understanding the comorbidities is just kind of something that plays into, what your life would look like. Does it? Well, sometimes I'm just going to give this example. When you get pregnant, you sometimes get diabetes or high blood pressure during your pregnancy. Is there something that affects you during and post treatment, or something shows up, that's new?
Well, usually what happens is that all these other life issues, medical challenges that a average person face, you can during your cancer diagnosis. Depending on where you are in your treatment algorithm, your susceptibility may be different. For example, if you're undergoing chemotherapy, we all know that the immune system is challenged at that point. So you may be more susceptible to different sort of infectious or viral. So certain precautionary measures that are in place. Luckily, during the surgical phase, the phase that I'm most intimately involved, is that it's usually not a very prolonged phase. Usually, a patient comes in, if they're going to have surgery, they have their surgery done, and then they're moved along the care continuum to the medical oncologist. Whether it's a lumpectomy, which is breast conserving surgery, or if it's a mastectomy. If there are any sort of medical challenges that developed within that phase, our system is designed so that the patient is optimized before they go to surgery. So we've got I involve my primary care doctor. This is the doctor that knows the patient much longer than I know them. They're presenting to me with a new pathology, their cancer, but they've got a primary care doctor that sometimes they've known for 10, 15, or 20 years. So I've always engaged a primary care doctor. If there's a cardiologist on board, we engage them. If there's a pulmonologist, because the patient has lung issues there. So there is like an infrastructure in place where you identify these other medical issues, or if they're developed while the patient is going through their cancer care, we can plug those patients in accordingly to make sure that all bases are covered.
Okay.
Yeah.
Yeah, so it's basically you have the answers before they go into surgery
Yes.
to see and understand what you can expect during surgery.
Big picture going in. The good news is my anesthesia colleagues, they won't let you in the operating room unless all those boxes are checked.
Okay.
There's what's called a preoperative clearance, so to speak, to make sure the patient
Yes,
is
you
in.
also want not to be like all of a sudden say, why is my patient coding on the table
It's a
here?
very bad hair day, especially in breast surgery world, if you have a code
Yeah, right.
in the
No,
operating
we want to
room.
know everything.
Yeah.
And the anesthesiologist needs to clear it, like you said,
Correct.
to have a successful post-op.
Yeah. I mean, you never want to exit a room and not be able to have good news for the family
There
after
you go.
surgery.
That's it.
Yeah.
That's it.
Introducing the next generation of 3D tomosynthesis from CubTech, delivering crystal clear, high quality 3D images with the precision of amorphous selenium direct capture. A large active imaging area ensures no detail is missed, and seamless integration with Gamma Pro streamlines your workflow. Studies show the Mozart system can reduce re-excisions by up to 50%, while preserving healthy tissue for better cosmetic outcomes. The result? Improved surgical efficiency and quality of care for patients.
When it comes to specimen imaging, there's only one name you need to know. It's CubTech.
So, Dr. Lawrence, how do you involve patients and families in shared decision making about treatment?
The process typically starts with building a foundation of trust. Um, I'm usually on the listening end without interruption for the first few minutes of the consultation, just to see where the patient is, what's important to them, the values, um, listening with empathy.
I'm going to stop you right there.
Yeah.
And I have a question for you.
Yeah.
So, when you're meeting with the patient and their families,
Mhm.
is it just you or is it a few other physicians along?
It's usually just me. Yeah. So the patient comes into the breast clinical practice. It's myself, the patient, and whichever family member, if they're choosing, that they bring along with them. And so it's just initially just listening uninterrupted, with empathy and understanding. And then I think it's also important to clarify roles. And I usually go about that by making sure they understand that it's going to be a decision that we make together, um, with taking into consideration my medical expertise, balanced with their preferences and life context, so to speak. And after I get a full understanding of their history, exactly what's going on, and what I think should be the surgical approach is I go through all options, including listing what are the benefits and what are the risks associated, and if there are any alternatives to what I am offering as well.
Okay.
I answer questions that they may have about that. And then more often than not, we're able to come to a decision in terms of what is in the best interest of the patient, and next steps.
Right.
You give them time to think about it, or
They do. So you don't have to sign a consent during your first visit. You're allowed to think about it. You can come back after, to sign a consent. Some patients may want to come back with family members who've perhaps had breast cancer that serves as part of their support infrastructure. I've had patients come back because they want their spouse to be with them. So more often than not, I would say the majority of patients who know they have a cancer diagnosis, they're coming in with their support infrastructure. With the availability of the internet, many have already done done their own independent research, so they kind of know what they want. So the majority do sign their consent, but they are always offered the option of coming back and have additional questions to answer if they have them, and then we sign a consent, and then my team gets into motion of planning an operative dates, the preoperative clearance, the labs, all the stuff that's needed for a safe surgery.
So an average person walking in the door for surgery, there is no particular picture that you can draw on one patient. So a person could have a family, could be single, could be a young person, and their support team could include people who want to support them and people who actually want to make the decisions for them. You navigate all of that.
Yes. So sometimes you're playing like the therapist role. At the end of the day, it's what the patient wants in terms of the decision making. And you're right, we do have other, I'd like to classify as advocates that may be present, and they may have their preference of what they want to do. But really, it's the patient. My ears are specifically tuned to trying to understand the patient's preference. And so if I don't think they're prepared to make the decision then, or maybe they want to come back by themselves or come back with somebody else, we find creative ways of making that happen for them.
Okay. And so, the internet in today's day and age plays a big part in the education the patients get, as per what their diagnosis is, what the treatment should look like, what, options are available to them. Does that hinder, what they kind of can access, or?
Sometimes it's information overload.
Yes.
And there's a lot of misinformation available on the internet. So we do sometimes have to clarify a lot of the misinformation and to try to get patients to understand that, yes, this person had cancer, but it's a very different cancer from yours. The stage is totally different. The approach is different. So we often provide them with guidance regarding reputable sites that they can access. The American Cancer Society has a great site. The Breast Cancer Foundation has a great site. Susan G. Komen. These are all portals with reliable, accurate, safe information that we can guide our patients to.
Well, that's true, because I always ask the question, where did you read that? And can you show me the link?
Yeah.
So I try to understand where they're coming from, basically.
Yeah.
Well,
I often tell them sometimes that the folks who post online more often than not is the ones who have not had a good experience. And so they're more vocal about it because they want it to be addressed. So that's usually more readily accessible online and visible versus those who've had a more positive, meticulous approach and a good outcome.
Right.
But I always remind them that breast cancer is a treatable disease, especially when caught early.
It's just like people will ask me if they come and they say, oh, this is what they found in the mammogram. Who's the best surgeon? Now I have to really figure out who's the best to work with all the things that you've talked about. So it's interesting to me that you've got this network. And this is what I have to say, to help them along. Because it's not just, oh, you go to this surgeon and that's the end of story. No. There's more to it. Yeah. Correct? So the question is, you do have a supporting staff, is what I understand. And you do have family of the patient to come. So this first visit is only them. The second visit could be the supporting staff. Am I right?
The supporting family members.
Yes.
Yeah, we're seeing a trend where we're seeing breast cancer in younger and younger women.
Yes.
But the average age for breast cancer within the United States is about 60, 61. So breast cancer still remains a disease of a mature woman. My mom said, you never say older woman. Mature woman. Yeah. And so for the subset of patients that I sometimes care for, while they may live in Connecticut, their children are all across
Right.
the US.
Right.
And so sometimes we find ourselves having to do just having discussions to include the children who may be living in Minnesota or maybe living in Florida or elsewhere.
Right.
So that it's a family decision, because sometimes they may not be able to get on a plane and be here right away to be with mom in Connecticut. So it depends. So it's really talking to the patient. One of the specific questions that we ask all of our patients, and our nurse navigator follows through on this, is, what is your support system like? Because that allows us to incorporate people that are decision makers who will support this individual across their cancer care continuum. So that's where it really starts out. Once we get to that point, then that's when we start helping to plug in all the different resources that they need.
Because we're really talking about outcome,
Yeah.
right?
Mm-hmm.
The surgery may be a success, but if the supporting group,
Yeah.
the staff between the hospital or the nurses, etc., and the family,
Mm-hmm.
if they're not in sync, there's going to be a little disruption in that healing process.
And that's where the whole holistic
Right.
piece comes into play.
That's important.
Yeah,
Yes.
it's crucial both during and after your cancer diagnosis.
Mhm.
We have resources or members of our team, for example, nutritionists.
Right.
We encourage patients in terms of their diet, a balanced diet that
Right.
incorporates fibers, healthy fat, lean protein. We all know that those foods have antioxidants that
Correct.
helps to boost the immune system and helps with tissue repair. I have conversation with my patient about maintaining a healthy weight. We know that increase in the weight, obesity,
Right.
it also contributes to the risk of recurrence of the disease,
Correct.
also contributes to the development of other diseases such as heart disease, and diabetes. So all things that hampers in terms of your well-being.
Correct.
So that's an integral part of what we do in terms of the holistic piece of it. And sleep.
Sleep is very important,
It's so important.
and we ignore it the most.
Yeah, but if you have the C word hanging on your head,
It's hard
you
to
can't
sleep.
sleep.
Well, adequate sleep supports the immune system. It helps
Absolutely.
with hormonal regulation, and I tell
Like
patients,
Shakespeare said,
Yeah.
sleep is the balm of nature.
it is, and it helps with emotional resilience.
Yes.
You know, like you said, the word cancer, it's very upsetting. It's very stressful. So
Right.
stress management is important. I tell patients about exercise.
Mhm.
150 minutes a week of moderate aerobic exercise
Right.
and some strength training exercises goes a long way. Some people do meditation, mindful meditation, Tai Chi.
I always say, do something that feeds your spirit because it should bring joy,
Yes.
right? So many times people say, what should I be doing to create that? And that's something we need to teach them, because all along they've been working so hard or being focused on so many things that they forget about themselves, right?
Absolutely.
Especially women, I feel. They're attending to every person in their family, but they haven't focused on themselves. And all of a sudden now they don't have a choice, but really focus on themselves.
Yeah. That's one of the areas of my of interest, because I often deal with a lot of high functioning
Yes.
women who neglected their own care, not intentionally,
Correct.
but because they're busy both inside of the home as well as at work. We also are dealing now with the sandwich generation.
Yes.
You're taking care of your younger children
Yes.
And your
And your parents.
your parents. And so you're in the middle and your health is neglected. I can't tell you how often I will see a woman executive in my office. They've had a mammogram, there's an abnormality, and just trying to get them back in for that biopsy.
I know.
For them to carve the time out, to come. And then once they get the diagnosis, you hear all sorts of
stories.
boxes that
Excuses.
needs to be checked before they can enter treatment. You know, well, this report is coming up. There's this transition where this deal is ongoing. And the
And
list goes
somehow
on.
this care is not their first priority.
It's not. They themselves are not their first priority. Kids may be getting ready to leave for college.
Mm,
So
You
it's the
know,
same old pattern that they're repeating
Yeah.
all their decades
Yeah.
of life.
of caregiving, caring
Yes.
for others.
Yes.
And so I usually encourage them to come back with their support system or support personnel.
so I think, the whole thing is that women juggle so many different roles.
Mhm.
My mom always says, and life was much easier before because everybody had a defined role in their, continuum, so to say.
Mhm.
So the men went to work outside, the women worked inside the house,
Mhm.
and you're taking care of the kids. But I think taking care of the household is not a 9 to 5 job.
Mm.
You're up early and you're there till late.
Mhm.
And you're not seeing the satisfaction that a man sees in their job. So here we are outside, we're kind of wanting to do what the man does as well. So we bring that on into our world, but we are still watching the kids. We're still watching our parents. We're still doing all the things that we were doing before.
Mhm.
So our load is much heavier.
Yeah.
And then when we need care, how do you manage all of these things is kind of the big part in the big picture.
Yeah. We a girlfriend of mine, Jill Fitzberg, and I a couple years ago developed this bosom buddy idea, which is really having an accountability partner. So it's someone in your circle that every year at this time we're going to get our mammogram together, and maybe we'll go for lunch after, or we'll get our nails done after. But just having an accountability so that you can, yeah.
The reason I say this, coming from another country, we're coming to the United States. We have now isolated ourselves in a certain way. So people say to me, well, where's your family? I said, my family is here in America. This is a network of people that I've created, which is a family here versus my biologic family, which is in another country.
Yeah.
So we need that. We need to bring in, and what's beautiful about this country is you have churches, synagogues, other areas where people do get together and can share. And I think what you're talking about in this particular case is how you bring that to your patients.
Absolutely.
That's important because no man is an island.
No, don't try to do it all alone. You
Yeah.
can't.
Right.
It's easier.
Right.
So that begs the question, when surgery is recommended, what should patients know to prepare themselves?
Yeah. I think there's a psychological piece to it, in terms of preparing, understanding why you need to take this path.
Right.
It's really for health reason to make you whole, especially women who are facing mastectomy. That can be a very difficult
Correct.
decision. I often say while our breasts do not define us, it's an integral part of our femininity. And when you're talking about complete removal in terms of mastectomy, there's a psychological piece that we all have to wrap our minds around.
Right.
And
It's like physical dysmorphia. It's just you have to kind of now, lay that to rest because then you have a different life altogether.
yeah,
Because there's a part of you missing almost.
yeah, it's the focus is on survival
Correct.
and being healthy again and to more life years
Yes.
with family and friends and being able to do all the wonderful things that you've dreamt of or aspired
But
to
I think
do.
also now with plastic surgery and the
The advances.
advances in that, people are not so afraid of it. Like they can say, okay, we'll do the implant or whatever. And so you would be working intimately with the plastic surgeon, or would you be doing it yourself?
No, we work collaborative with a plastic surgeon. So you are right in terms of surgery for breast cancer has evolved over the time. I mean, I have patients in my practice who've had a mastectomy that you would never be able to tell they had a mastectomy unless they chose to tell you that they had this procedure. Because we're now able to do what's called nipple sparing mastectomy.
Yes.
We use an inframammary incision. We do hidden scarves for lumpectomies. We're now in the era where we're doing nerve preservation in terms of nipple sparing mastectomy,
Wow.
where you literally go in and you scoop out all the breast tissue, and then the plastic surgeon comes on board and does the reconstruction. One of the things I think we're supposed to talk about a little bit later, we can touch on it now, is your options for surgery when you're facing breast cancer, a lumpectomy versus a mastectomy, and what is the difference between the two. So for a lumpectomy, essentially you're removing a part of the breast, the part that has the cancer with a rim of normal tissue around it. For a mastectomy, you're removing the whole breast.
Correct.
And once a woman is facing the decision of a mastectomy, we offer them the option for a consultation with a plastic surgeon to discuss your options for reconstruction. And not all patients accept. There's some patients who say, Dr. Lawrence, I'm at a stage in my life, I do not want any reconstruction. I just want to be flat. In fact, I'll put a plug in for a book that I did with Kat Van Dam called Flat and Happy. Because when she went for her surgery, her mastectomy, she elected just to proceed with the mastectomy without reconstruction. Now, if a patient is thinking along the lines of reconstruction, preliminary, I'll sort of set the stage before they meet with a plastic surgeon. There's really two big options when it comes to reconstruction. Either you are going to do like an implant-based reconstruction, or alternatively, you're doing what's called autologous reconstruction. And what that means, autologous is meaning that you're using your own body fat tissue. I mean, it can come from the latissimus, which is at the side. It can come from the abdomen. It can come from the buttocks area. But the whole idea is that it's your tissue that's going to be utilized for the reconstruction. And then when they see the plastic surgeon, he or she will go through what to expect. They usually have visual tools that will help you to have an understanding of how the process works. And it's never a one and done surgery is what I tell patients as well. Once reconstruction is, there's some tweaking that may be needed. They'll also talk with them about the risk and the benefits that are associated.
Having either or.
Either or, exactly.
Yeah. So from what I understand, Dr. Brown, if you have an implant, you should go back at least within 5 years to make sure it's.
So if you've had an implant from a mastectomy, usually you're still going to be followed by your cancer doctor. There's no mammogram needed after mastectomy. So the goal of mastectomy is to remove all of the breast tissue.
Got it.
So there's no routine screening after you've had a mastectomy. The breast tissue is gone. You're usually followed by clinical breast exams. And typically, if any sort of abnormality would pop up, it would be right beneath the skin that you should be able to appreciate in a clinical exam. And usually, if something is identified, it's followed by what we call a targeted ultrasound, an ultrasound of the area. For some implants or there's always a risk of rupture, risk of leakage, et cetera. The current recommendation is that we follow these patients with an MRI that assesses the integrity of the implant. And I believe it's done like 2 years. But we have implants now that last, more than 10 years. And this whole phenomenon is based on the type of implants. There's saline implants, there's silicone implants. So there's a lot of discussion that goes into that, which usually occurs between the patient and the plastic surgeon.
So that's post their mastectomy or their surgery?
No, that's before surgery. Yeah, times have changed. Now when a patient is facing a mastectomy, we work collaboratively with the plastic surgeon. Everything happens the same day. Same day, same operation for the initial surgery.
Well, that's helpful because you're not being cut up so many times. I'm sorry to say. But it's one time, you've got it all figured out.
So you don't wake up flat. If you don't want to be flat and you're working with a plastic surgeon, you won't wake up flat. So typically, my job as the oncology surgeon is that I go in, I remove the breast tissue. We always do a axillary staging, whether it's a sentinel lymph node biopsy or axillary dissection. And then the plastic surgeon comes in and they utilize that skin envelope for reconstruction.
So it's all done in one surgery.
One surgery. You may need to go back subsequently with the plastic surgeon
Okay.
for a complete exact follow-up and completion. So a lot of the reconstructions that happens now that are implant based, typically a tissue expander is placed.
Okay.
You expand the patient to the size that they've agreed upon, and then
Right.
the plastic surgeons will go back later to put in the permanent implant. It's a different story if it's autologous using your own tissue. That phase is usually omitted.
So what do you think is, I think it's a personal choice for patients to decide whether it's autologous or an implant. But what is your opinion on that in terms of which one is better?
I don't think either is superior.
Okay.
I think it has to do with the risk that comes with each. I have patients who say, I don't want any foreign body, implants, so they will never do an implant. They'll more likely to use their own tissue. The risk of infection is different for an implant. If it does get infected, it's got to be explanted. It's unlikely for you to have an infection that require you to have your flap removed for autologous reconstruction. And it also depends on how much surgery and anesthesia you can tolerate. An implant-based reconstruction is a much more quicker, 1 to 3 hour surgery versus autologous is surgery on two parts of your body, the breast and wherever you're harvesting the tissue from. It's a very specialized procedure done by micro plastic surgeans. It takes several hours. So, it's weighing all of those with patients' preference and their comorbidities that helps too.
Well, it's a philosophical question. And that is the fact that a part of them is being removed. And I was thinking of Kubler-Ross, who wrote about death and dying, and who said there are different stages in the expression of the human emotion, like, why me? How did I get this? What's going to happen? The anger or the sadness. And I think your team can really work with that, because I, as a naturopath, also work with that and see, because healing has to be on hope, not on dissolution of hope, So I was thinking of what Kubler-Ross was talking about in terms of parting with the tissue that no longer is serving them. That's it.
Well, there are different variations of that presents to the breast center, and there's some patients who are very open about it. They'll talk, and there are others who are more private, and it's perhaps a conversation with their significant other. In terms of the stress and the anger, we're actually, our team, we have conversations about this. So we sometimes have patients who come in and they are angry, not at us, but why me?
Correct.
The life situation.
Yeah. And so we are attentive to that, so that when we get that angry patient that walks through the door, we are equipped in terms of how to deal with that emotional side, because we know it has nothing to do with us.
Right.
They're navigating a very difficult path in life.
Emotional path.
Yeah.
Yes.
And so hence the emotions that we see, which is anger, frustration, blame, so we find creative ways to help them navigate and to plug them into the appropriate resources that we help.
That.
Yeah.
And then accept the fact that this is the new journey.
Correct.
Right.
Yeah, I think I'm gonna, sound off on as a patient. If I was to be diagnosed with something like this, the thought that goes through my mind is, I have so much going on, and I have to put everything to the side, and I have to now lose my breast. I'm gonna look so different. What the heck?
Yeah.
Like, why is life treating me like that? So can I not go through this? Can this be, just something I need to put on the back burner and attend to later? But no, we
need to. Yeah.
So that's a lot for someone to talk to, essentially. I think as a surgeon, you have to talk to that.
Yeah, you do. And we do get patients who come in who The denial is still very much present, and they're just not ready yet to embark
Are
in
you
treatment.
sure?
Yes, are you sure? And we also help to facilitate second opinions. I often tell patients, if you desire a second opinion and your clinician tells you no, not a good idea, maybe it is really a good idea for you to do it. Because if you know that you're offering the best, the state of the
Yes.
art, the standard of care, and a patient wants to see another clinician, that should be fine. It's going to be validation of what you
Right.
are offering,
Right.
and you should be comfortable. If anything, it's going to help to build rapport because they go and they see they're getting the same
Yeah.
information, the same procedure being offered. And I've had patients who've had second opinion. The majority
Right.
end up coming back, but I think it's good for them to hear it from a second source
Right.
as well.
Absolutely.
You know?
Absolutely.
It's a lot of trust coming through then.
Yeah.
You know, from what you heard from the first and then the second as well.
Yeah.
Yeah, for sure. So I just wanted to kind of have an explanation of what is a sentinel node biopsy and why is it important?
A sentinel lymph node biopsy it can be more than one.
Mm-hmm.
It's really the node or nodes where the cancer traveled to from the
Okay.
breast, those first nodes. Whenever a woman has breast cancer, especially when it's caught early, it
Mm-hmm.
tends to be confined within the breast.
Okay,
But if it does leave the breast, the first place it goes to is those sentinel nodes.
got it.
So at the time of your surgery for invasive breast cancer, not
Mm-hmm.
for DCIS. DCIS means ductal carcinoma in situ, and that is early stage 0 breast cancer. This
Okay.
disease is confined to the breast. There's no need to look at sentinel node at the time of surgery. But if you have stage 1 cancer and beyond, that's an
Right.
invasive type of cancer, it's important to assess the lymph node, the sentinel lymph node at the time of surgery.
Okay,
So that's what the sentinel lymph node process,
that's the
because
importance
it
of
helps
that.
to guide treatment,
Yes.
whether the cancer is only in your breast or whether it's made its way into the lymph nodes.
So
Okay.
a question on that is lymphedema.
Hmm.
So if just doing a biopsy, would that cause lymphedema or?
Very rarely. The current data shows that the risk of lymphedema associated with sentinel lymph node biopsy is probably about 3 to 5% or so. So
Okay.
it's very low. The concern for lymphedema becomes much more of an increase in priority when we're talking about complete axillary dissection. That's removal of all the lymph nodes in the axilla. And that rate jumps up, to 1 in 4, so about 25% of patients. So we often have those patients consult with our occupational therapists and our lymphedema specialists, both before surgery as well as after surgery.
Okay.
So there are different techniques and treatments that are available to help mitigate the development of lymphedema.
Okay, so I have a question for you and I have a question for you. So I'm going to ask you first, even though I know you need a break, but from answering so many questions. Can you walk us through the day of surgery from check-in to recovery?
So typically, you would enter the hospital, you'd be directed to the surgical floor. There, the outpatient ambulatory surgery centers where a lot of breast procedures are performed. Once you're checked in, you'll get to meet with your nurse. There is a certain checklist, preoperative checklist that, questions they'll ask you. Important questions such as when was the last time you ate? Because that's important for our anesthesia team. It's
Right,
also,
right.
that's the time when you'll meet the anesthesia team.
Okay.
And now, because you're meeting the anesthesia team the day of surgery, they have looked at your chart well in advance. They're anticipating your arrival. They'll ask you any additional questions. They will talk to you about the anesthesia, how it's done, what to expect, both before, during, as well as
Right.
after. They always ask you about, have you had anesthesia before? Any problems? Any difficulty with nausea and vomiting? Because there's things that they can do. They've got all sorts of tricks in their tools that can help to mitigate some of those side effects
Right.
from anesthesia.
Post-surgery then.
Correct.
Yes.
And then if you're having breast conserving surgery or a sentinel lymph node biopsy, it's usually done at the bedside in terms of the dye that's injected to map the sentinel lymph node, or in some institution, you may need to go to the radiologist suite where that's done. Then eventually you'll make it into the operating room where you meet the full OR team that's involved. Everybody will introduce themselves. There are certain safety precautions that we have in place, right patient, correct patient, correct procedure, et cetera. With the entire list that we go
Yes.
through, the patient is awake for that part, so
Yes.
they're an active participant in that piece of it. And once that safety piece is completed, then the induction of anesthesia starts. And the surgeon does her surgery, his or her surgery, and then if it's a plastic surgeon on board, that person comes in and starts with the reconstruction. At most institutions with the advances in technology, there's usually a billboard that's outside in the waiting area.
Right.
It doesn't have any of the patient identifying information, but you're usually given a number that tells you what number corresponds to your
Okay.
loved one, so you can see where they are in the phase of the surgical
surgery.
process. Are they in the OR
Interesting.
yet? Are surgery done? Are they in recovery? Phase 1,
That's
phase
very
2.
helpful.
So it keeps the family looped in and informed. I and myself, and I would say the majority of my colleagues, usually you reach out to the family after surgery just to give them a insight as to how the surgery went and how their loved one is doing.
Right.
Yeah.
Okay. Yeah, that's very helpful because, it's kind of I'm not sure everybody understands the implications of, how many people are working on you and can your family stay out there for that long? Should they stay out there?
Yeah.
All of those questions
Yeah.
come up.
Yeah, some family members will leave and come back. Some will stay in the hospital.
Yeah.
It makes them more comfortable to be within proximity. It's really a personal preference.
All right, Dr. Pram. So, what role do food supplements or mind-body practices play in supporting healing and reducing inflammation after surgery?
Well, I think it starts pre-surgery too, because you got to prepare this person for that particular event, correct? So I really talk about starting an anti-inflammatory diet way before they come in, like you talked about, and things that they could do, what supplements they could take to build up their immunity, and then to stop certain supplements before they come in for surgery, because sometimes they could actually cause bleeding and ecchymosis, which is, bruising in a certain way. So we want to be able to prepare them for that. Then they have the surgery, and then during that time, there are things, there are preparations that we can give them for healing the wound, so as to speak. So it's very calm and not inflamed, because the first 7 days are always sort of, is there any infection?
Critical.
Yeah, right. So we want to prepare them for that as well, from a nutritional point of view. From the long term, of course, depends on the terrain, depend what's coming up. And that's why it's very individualized. If you just can't say do this for everybody, it's no, what's that cookie cutter thing in here. But we have options to share with them, and share with the surgeons, share with their primary care, so we're all on the same page. And many surgeons will say stop all supplements. So we look at that, and say, okay, stop it, and then start again at a different point in time. So we do work with everybody. In terms of the mental, emotional, that's important. I always say, learn to have fun. Learn to enjoy your life before, during, and after. You've got to have that expression. And they'll say, what can I do? And it could be anything from, having good intimacy to be able to share themselves with their partner before they go into surgery. Because after that, it'll be a different ballgame. So, we want to prepare them to have that closeness.
Yeah.
So, for example, what would you suggest, it's just, in basic terms, what is an anti-inflammatory diet?
Well, usually it's something that, like you had said, increase the fiber, increase the, it's like a Mediterranean kind of a diet.
Fruits and vegetables.
Yeah, fruits and vegetables. There's so many things that you could be doing, especially even seeds. Certain kinds of seeds are important, like flaxseed for the fiber, chia seeds. There are many things that, again, depend. I know people say, what do I do with these seeds? I don't know anything about them. And we give them recipes. We get them involved in their own well-being.
So you did mention that, before surgery, they should stop certain supplements which
Yes.
make them bleed.
Yes.
So can you
Yes.
put light on that?
Yes. So they should stop vitamin C,
Mm-hmm.
omega-3s, turmeric, because these could increase bleeding issues.
So we often ask patients, are they seeing a naturopath and what supplements are you on? And, some patients are sometimes hesitant to disclose, and I tell them, no, this is all important information,
Right.
that you share between
Correct.
those who are treating you so that one doesn't impede the other. Because
Right.
if you're taking something that increases your risk of bleeding, I would
Right.
like to know before I
Right.
get into the operating
Correct.
room, so that we can plan accordingly.
Yeah. So I think,
Because those three things I mentioned are anti-inflammatory, but when they go before surgery, they have to stop it.
it's kind of a good, a way to explain to a patient, if you're being told not to do the supplements, there is a reason. I just wanted to kind of put it out there for
Right.
people to understand that.
Post-surgery, we can talk about taking bromelain and other healing foods, like papaya. Okay, it's
So
foods.
it could come from foods or supplements,
Correct.
but foods are recommended.
Correct. I prefer foods.
That's a good way to
Yeah,
understand
approach, yeah.
what is the best way to heal yourself,
Right.
essentially. All right, so I think, we're kind of at the end of this, and I just want to say I always believe in this too shall pass. And what should my plans and dreams include now that this has passed? So please, can you share a positive message with patients and families about life after breast cancer that are listening right now?
Yeah. I would say breast cancer does not discriminate. However, when caught early, it is a very treatable disease. There's a reason we have over 3 million breast cancer survivors in the United States alone, and that's due to advancement in treatment, as well as diagnosis and early detection. So I often tell my patients that if you notice an abnormality within the breast, either just self-breast exam at home, or if your clinician identifies an abnormality or you have abnormal mammogram or ultrasound, please follow through on the recommendations, because when caught early, breast cancer is a very manageable disease, but early detection is key.
So, Dr. Lawrence and Dr. Pram, thank you so much for sharing your expertise and compassion today. So, this episode builds on our earlier discussion with Dr. Krishnan and Dr. Jones, covering prevention, risk reduction, and oncology treatment. If you missed those episodes, please go back and listen to them. The links are in our show notes. Together, these conversations form a complete guide from detection to treatment to surgery, recovery, and life beyond cancer. Our goal is to empower patients and families with knowledge, comfort, and hope. Remember, early detection saves lives. Please schedule your screenings and encourage your loved ones to do the same. Thank you for joining us on the Mood Food Podcast. Be sure to like, follow, and subscribe for more conversations that nourish the mind, body, and soul. And until next time, stay well, stay hopeful, and remember, food, intention, and care can all be medicine.